Good evening, everyone, and welcome to this evening's presentation on clinical psychology. Clinical psychology, in this case, being the combination of abnormal disorders and therapy. Now, this is something I tell every psychology class, be it here at Fiveable, be it in my college classes that I teach, in my high school classes that I teach, that you should never, ever take this information that you learn about in an intro to psych class and start diagnosing anyone or trying to give therapy or anything like that, especially to yourself. There are times where a student might hear about a certain disorder and says, I have that. I know I have that. Well, that is not up to you. Well, you don't have the skills and the training to make that determination. Neither do I. I'm not a clinical psychologist, and even if I was, I wouldn't be doing it over a presentation like this. So that's if you do see something here and you say, I think this is something I should follow up on, or this is concerning to me, or I'm concerned about this because I think it might apply to me. It's something you should talk to your parents, your doctor, or counselor, a trained professional who can basically make those determinations, because there's a lot that goes into diagnosing. And what you are seeing here, this evening's presentation, is a sort of, shall we say, textbook presentation of these disorders. In other words, we talk about, bipolar disorder is X, Y, and Z, and dissociative identity disorder is X, Y, and Z. But it doesn't always so clearly manifest in those ways. And I want to make sure that's very clear as we go through this. Not every disorder is as, for lack of a better word, obvious as the way it is presented this evening in terms of the symptomology and whatnot. It's presented because these are the symptoms and whatnot that you need to know in order to do well in the AP exam. So given that, I am going to start with sharing my, let's see here, Unit 8, there it is. Whoops. All right. And I'm going to present. And captions. Okay. Looks like we have them up and running. Very good. And it is showing up on the Vimeo screen. That's good. Occasionally, you will see some review questions of stuff that is talked about this evening. And see if you can answer it in the chat, and see if you are able, if you come up with the right answer, and see if your classmates, for those who are here with us, also can come up with the right answer. Now, I know you can always look in your notes, or you can look at the slides and say, oh, okay, I can find it. I want to see if you can do it or answer it by your own memory. And if you can't, that's okay. It's, if you're learning this for the first time, especially, that can be difficult. But see what you can do without the assistance of notes, because when you take the AP exam, you're not going to have the assistance of notes, or you're not supposed to at the very least. So try to see what you can do from memory as we talk about these things. All right, our social media. So this is something, now this is going to be a longer discussion, which we don't have too much time to talk about here. But a person comes to a therapist and says, I hear voices that other people cannot hear. Does that person have a psychological disorder? And the short answer to that is, by itself, you cannot make a determination because there is much more to it. More information is going to be needed. There are people who, for example, are who might be considered a soothsayer in particular cultures, where they are born with what is perceived by others as a gift to be able to talk to, let's say, spirits or to the dead, and people will turn to that person for advice. And we're not going to say in that instance that person has a psychological disorder, especially if they're functioning productively even in that culture. Let's say they're not bothered by it. I'm not going to call it a disorder. But let's say the person says, they're invading my life, and they're saying bad things. I can't live. That's where it might become clinically relevant and clinically significant. You see, that's a thing. It's not just about the symptoms, but there's more to it. An abnormal disorder, okay? Basically, these are the general criteria. And just generally speaking, it's an abnormal disorder. If a symptom of some type of symptom threatens oneself or others, possibly, not necessarily, it could be threatening to oneself or someone else. It interferes with one's ability to live. And those two kind of interact with each other, or they could interact with each other. The idea that it deviates from cultural norms or it's eccentric by itself is insufficient criteria to call a mental health disorder. Just because it is unusual relative to one's culture doesn't necessarily mean that it is a clinical disorder. There has to be the ability, the interference with one's ability to live, or it's threatening to oneself or someone else. So that's just something to understand. But just the fact that it's unusual is insufficient to call it a mental health disorder. Two general approaches to how we diagnose mental health disorders. There's the biopsychosocial model, that's a big word right there, and the biomedical model. Also a big word, but not quite as big. Okay, basically, the biopsychosocial model believes that the causes of mental health disorders are the interaction of biological, mental, and social interactions, whereas the biomedical approach assumes it to be a biological disease, something wrong with the brain, something wrong with the neurotransmitters or the hormones, or something wrong with the body that's causing it. Where the prognosis, the biopsychosocial model says, well, we're going to try to manage it. We're going to make it so that you can live a high-functioning life, whereas the biomedical model assumes that the condition is curable. And finally, the idea, what they consider to be well, is being able to properly function in life if you subscribe to the biopsychosocial model, whereas the biomedical model assumes that it's the absence of psychopathology or mental health, of a mental health disorder. Now, these are not, it's not like two camps that are two divided factions that don't share any variants in common. They're basically, it's a, what, both are basically correct. Much like everything else in psychology, it's not like one is absolutely right and the other is absolutely wrong. Basically, we tend to be a lot more eclectic in the approach to mental health disorders. It's probably a combination of all of these things. So, okay. It's the DSM-5 that we use specifically, we being clinical psychologists. I'm not a clinical psychologist, so I'm not trying to put myself in there, but that psychologists use to diagnose mental health disorders. There are other publications out there, but for our purposes, we are going to say it's the DSM-5. It has diagnostic criteria. It says these are the conditions that must be met in order to have that clinical diagnosis. It tells you how prevalent it is. In other words, how often does it appear in the population? Does it affect 1% of the population, 20% of the population? Very, very rare, like 1 in a million? The DSM-5 will describe that. It tells about, if it's relevant, when does it typically come on? When does it normally start appearing? Schizophrenia, for example, is classically known to start appearing in late adolescence, whereas something like attention deficit hyperactivity disorder is more noticeable or is more likely to be noticed in childhood. So the DSM will tell you what things to be in terms of age. Cultural issues that, okay, a person says they have this experience, this experience, and this experience. Well, given the culture that they live in, is that necessarily a diagnosable disorder? And the DSM will say that, in this culture or in this area of the world, this might be considered normal. So cultural issues play a role. It doesn't tell you how to treat the mental health disorder. It is not a prescriptive textbook on, say, well, if a person has major depressive disorder, you do X, Y, and Z. That's not what the DSM does. All right, so we're going to go into our first category of mental health disorders. But before we get to that, I want to kind of talk about, somewhat philosophical, this idea of awareness. Let's assume that this blue circle represents what you are aware of. It's your entire world around you, and it can include your thoughts and memories. It's basically your entire awareness. But let's say you lose awareness. Let's say you get so focused on something, like you're reading a book, and everything else just channels out, or you're so absorbed in your own thoughts while you're driving that you drive home safely, but you don't remember any part of the drive, or you're so engrossed in the movie that two people are talking behind you and you don't even hear it. This loss of awareness, by its very basic definition, is the how we might define dissociation. Dissociation is and I don't want to say everything is dissociation. Some say everything is, but basically dissociation by its basic definition is a loss of awareness. It's losing awareness of something. It's limited to a specific external reality, or it could also be limited to an internal reality. In other words, I'm so focused on something that everything else channels out of me. So, and this is how, even though hypnosis is not part of this curriculum, it's a very strong, a lot of people subscribe to the idea that hypnosis for pain control, a person could have surgery, like where they're literally cutting open the skin and doing surgery, and the person doesn't feel discomfort under hypnosis because they're tapping into some dissociation where they lose awareness, for lack of a better phrase, of the pain. There's always some part of you that's aware of the pain, but it's kind of split from your awareness. Now, dissociation is a very normal thing. It's something that we all do at various times in our lives. But like anything else, too much of anything can be bad. And do we, and when one, I should say, starts relying on dissociation to function, like it becomes over-relying dissociation, that's when it becomes a dissociative disorder. Dissociative amnesia is a loss of memory. Now, Freud called this repression. Today, we call this dissociative amnesia, usually because we've experienced something so traumatic, so horrible, so terrible that we literally block out the memory. I'm not talking about brain trauma where there's like an injury to the brain, but it's literally blanking out a memory or blocking a memory so you don't have to access it. That's dissociative amnesia. There's a rare part, or a rare form of it called a fugue state, where a person loses complete awareness of who they are. This is exceedingly rare, so rare that it's limited to case studies. It used to be its own mental health disorder, but now it's kind of a subsection of dissociative amnesia. So the fugue state is losing complete awareness of who one is. And usually when a person's in a fugue state, an odd characteristic is they tend to flee the situation that they're in. They strip themselves of any identity and just run away. And it's documented in numerous cases. Depersonalization, derealization disorder. This is where we've all had the experience of being on autopilot, where we're just kind of going through the motions. We're not even, it just feels like we're just kind of doing and not really doing it. Well, what happens if it gets to the extreme where the person feels like they can't even control like their daily functions? They feel like there's what they sometimes call alien control, not literally aliens from outer space, but some other force controlling you. Okay, that's that depersonalization part. Whereas the derealization part of it is where you're questioning whether this is your reality. Sometimes we wake up and we say, "Gosh, was that a dream I had last night, or did that really happen the day before?" Think about a person who is questioning most parts of their lives. Like, is this really my reality? Am I really awake? I don't know. That's the derealization part to it. Then there is the well-known dissociative identity disorder, formerly called multiple personality disorder, where a person takes on different identities because each identity might serve a particular function. Some people call it an ego state that it tries to serve a certain purpose, because for whatever reason, the base personality, for lack of a better phrase, the base personality is not able to handle it or do it because it's so unlike them, so that they take on a different personality and then have a dissociation. They block out that memory of that alternate personality because there's so much unlike them. Again, I'm taking a very complicated disorder and kind of simplifying it here. What's interesting is that usually at first the base personality is not aware of the other personalities, although the alternate personalities are aware of each other and the base personality. Okay, so that's dissociative disorders. And dissociative disorders, once upon a time, were once thought to be the same thing as schizophrenia. As it turns out, these are two completely different disorders. And some are of the opinion that you can't have both even. There are some who talk about case studies where a person did have both, but there are some who are of the opinion they can't have both because they're just so different. Well, regardless, schizophrenia has two categories of symptoms: positive and negative. Recall from our talk about positive reinforcement and negative reinforcement that positive and negative not meaning good or bad. It's the same thing here when we talk about positive and negative symptoms. When we talk about positive symptoms, we're talking about the presence of behaviors that, for lack of a better phrase, shouldn't be there, whereas negative symptoms are the absence of behaviors that probably should be there. So if you think of it that way, that's what we mean by positive and negative symptoms. Now, positive symptoms might include hallucinations, hearing, seeing things that are not there. There's other types of hallucinations too, but for our purposes, we'll stick to that. There's something called negative hallucinations too, but we'll just stick to these type of hallucinations here. Hearing things not there, basically it's perception without sensory input. It would be the type of the hallucination here. Delusions are these odd or irrational beliefs that persist even if you are given contradictory information. You say, well, the aliens are coming down, and I give you all the evidence in the world that the aliens are not coming down, and you still, maintain the belief. Paranoia, you feel people are watching you, people are after you. Inappropriate emotions, you are expressing yourself with inappropriate emotions at the wrong time. Disorganized thoughts and speech, you have random thoughts going through your mind. Your one's speech might be totally jumbled and makes no sense at all. That would be the disorganized thoughts and speech. Now, negative behaviors, or negative symptoms, I should say, include catatonia, which would be a loss of movement. Now, classic catatonia might be a person's movements are just very, very rigid, or they're very, very fragmented, let's say. There's like a lack of movement where there should be movement. Flat affect is a lack of emotion, a lack of affect, a lack of emotion, showing I don't want to say it's a poker face, but it's showing no emotion whatsoever. Some say, well, the person might be depressed. And not surprisingly, a person with schizophrenia is likely to also be diagnosed with major depressive disorder for that very reason. But here we're talking about a flat affect. Now, possible causes of schizophrenia, and these have appeared on various forms of the AP exam in the past. High dopamine levels are associated with schizophrenia, and enlarged brain ventricles being the gaps in the brain that we all have, and it just so happens that people with schizophrenia tend to have larger ventricles. Whether that's the cause of schizophrenia or a byproduct of schizophrenia is not exactly known, but that is two possible causes of schizophrenia. And there are drugs, when it comes to dopamine, that try to reduce the amounts of dopamine in the system, which we'll talk about later on. The Diathesis-Stress Model basically it's a model that describes how mental health disorders occur. Is it genetic or environmental? Obviously, the answer is both. Basically, the Diathesis-Stress Model suggests that we all have a genetic predisposition to, let's say, some particular disorder. It could be high for some or next to none for another. And whether or not it actually comes out depends upon how stressful the environment is. So if I have a very high predisposition to schizophrenia based upon my genes, but I live in a very warm and encouraging environment, then maybe that schizophrenia doesn't actually manifest. Likewise, if I have let's say I have a moderate level of genetic predisposition, but I have a very stressful life and I have relationship problems and everything else, then maybe it comes out. Okay, that's the idea behind the Diathesis-Stress Model. All right, we move into another category of disorders. It's the major depressive disorder, or what we call depression. And it's often associated with sadness, but it's more than just sadness. We all have periods of sadness in our lives, but the idea behind major depressive disorder is that it's a prolonged amount of sadness with other types of things attached to it. A loss of interest and pleasure in things that used to give us lots of amount of pleasure and happiness. We might have loved playing the guitar, and then suddenly we wake up one morning and we don't want to ever touch the guitar again because we feel so sad. We can't concentrate. We feel worthless or guilty about something, maybe something that you have no control over. Getting more or less sleep, weight loss or loss of appetite, restlessness or inactivity. And it's not just, and a person could have this for a couple of hours, let's say, maybe they encounter something that was really saddening. But this is something that occurs over a 2-week period. We're not just talking about, I just had a rough hour. We're talking about 2 continuous weeks, 14 straight days of this in order to get the major depressive disorder diagnosis. There are variations of major depressive disorder that used to be their own separate things, but now kind of like subsections of this. Postpartum depression is the The depression a mother feels shortly after giving birth, she might feel sad, she might feel guilty, she might feel like she's not adequate enough to be a mother. It used to once be called the baby blues. Oh, everyone gets over it. Well, it turns out it could be a lot more serious than that. And they take it very seriously if someone says, I'm having postpartum depression, and doctors will take that very seriously. Seasonal affective disorder usually occurs in the winter, less sunlight, we're indoors more, and we're just, it kind of starts to get to people, for lack of a better way of putting it. And there was some talk about how, even though it wasn't seasonal, during quarantine, during the shutdowns, there was maybe something that would be normally seasonal affective disorder because people were inside and didn't get out as much. But anyway, that's seasonal affective disorder. Now, one of the things we have to also look about in this unit is the attributional style that is often closely tied to major depressive disorder. It's your attributional style. How do you interpret life events that occur? People who have a positive, and this time we're talking about like positive meaning good, okay, or an optimistic attributional style, I should say, and when bad things happen. Basically, good things happen to us and bad things happen to us. How do we interpret it? Well, those who have a positive, in this case, positive actually means good. Positive, those are the positive attributional style. They interpret life events. When good things happen, they say it's internal, stable, and global. I got that promotion because I'm a good worker who worked hard on all of my assignments. Internal, I had something to do with it. Stable, happens all the time. Global, applies to everything that I do. When bad things happen, I didn't get the promotion because a few things beyond my control prevent me from getting noticed. Better luck next time. Basically, it was beyond my control, external. It happens once in a while, temporary, and it only happens here. It doesn't apply to my entire life, specific. Okay. Now, could you be right or wrong in these attributions? Certainly. But nevertheless, that's what they tend to do. Now, those are the negative attributional style. Basically, it's the exact opposite. When a person gets some good happens to them, oh gosh, I got lucky. I don't think I'll ever get lucky again like that. Basically, it's beyond their control. It happened only once and only applied to this. And the negative attributional style for bad things happen, they internalize it. It's their own fault. It happens all the time. And so essentially here, it is, and what we find here, not surprisingly, is that people with major depressive disorder tend to have more of a negative attributional style. Now, it's not like you have all of the positive or all of the negative, and it could be situational, but these are just two general categories here when it comes to attribution. Bipolar disorder is, it used to be called manic depression, but it's called bipolar disorder, consisting of depressive episodes, just like major depressive disorder, but also has manic episodes, which are often characterized by high amounts of energy and euphoria, lack of sleep, racing thoughts, rapid speech, difficulty focusing, excessive spending, or gambling. This is when the person's not depressed. It's as if it's the exact opposite. They are on high alert. They are not sleeping at all. They're doing all sorts of things. They have a great sense of euphoria, like I'm the greatest. Nothing can stop me. And you might say, gosh, that sounds great. Well, the problem is that there's no limitation, or there could be very little limitation. They think they can't, they're not sleeping for 4 or 5 days straight because they're doing schoolwork, because they feel like they're the greatest student ever. And that obviously that could be quite problematic. There is another type of mood fluctuation called psychothymic disorder. The psychothymic being here in the gray. The red represents the bipolar disorder, with above the line being manic episode, below the bottom line being depressive. That would be bipolar, whereas psychothymic has the variations, but it's not quite as strong. So psychothymic is kind of like I don't want to say a lighter version of bipolar, but not quite as strong a polarity as the bipolar disorder. Okay, so real quickly, just to see if you can answer this in the chat, I am going to keep moving on here. Can you name 3 dissociative disorders? You can do that in the chat. That would be great. Obviously, it's optional, but see what you can do with that. See what you can do. So, all right, moving on here. Anxiety disorders. Anxiety disorders refer to what a person calls anxiety. But here, generalized anxiety disorder is what we normally call anxiety. Low levels of anxiety that are ongoing. The person's like kind of like ongoingly nervous. it just feels like they're nervous all the time. It's not too extreme, but it's almost like they're on edge, always kind of nervous about something. Whereas panic disorder, on the other hand, is characterized by these panic attacks, which are episodes, brief episodes that might last 5-10 minutes at the most. And it's an extreme feeling of dread. They feel like they're going to die or the world's going to end. The sympathetic nervous system kicks into high gear. Heart rate's pumping very high, breathing very heavily, and so forth. It's very extreme compared to to generalized anxiety disorder. It's just like kind of like being nervous ongoing. Panic disorder is a completely different thing where a person could be just, for lack of a better word, normal, not having the anxiety, and then suddenly, boom, comes on, is extreme, 5-10 minutes later, goes away. And it can happen daily, it could happen once a week, it could happen once a month. The DSM does have criteria, though, about how often it has to happen. Specific phobia is an irrational fear to something. It is rational to be afraid of going into a burning fire. It's irrational to be just as afraid of a picture of a candle burning. It would, it's irrational. A person who cannot live their life because they have this fear of something that's irrational, that's where it's called a specific phobia. Just to kind of give you a kind of simplified presentation here of the difference between generalized anxiety disorder and panic disorder. You can see that the generalized anxiety disorder kind of like ongoing, always there, whereas panic disorder, if this represents levels of anxiety, not too much, and suddenly very extreme every so often. Obsessive-compulsive disorder. Two aspects to this, to obsessive-compulsive disorder. Obsessions are these thoughts that are invasive, they are causing anxiety, and they can be irrational or bizarre. And the persistence kind of makes them irrational. So a person says, I left the lights on, and not so much irrational, but the person in that case, it keeps thinking about the lights being on, and just can't stop thinking about it. And it could be irrational, where it's like the aliens are coming down. Not necessarily all people with OCD, but to an extent. Compulsions, on the other hand, are the behaviors that are rituals that repeat themselves, that are hard to hold back, with the intention of trying to alleviate the obsessions. A person, for example, the classic prototypical one being hand washing. My hands are dirty. I have to wash them. So they wash their hands. The thought being, my hands are dirty. Now, they might even know cognitively that their hands are clean enough to live their life. That the perfect cleanliness is not possible. But yet there's still those thoughts going through their mind. My hands are dirty, and so they engage in this hand washing behavior, where they wash their hands 5, 10, 15 times, even more, to try to make those thoughts go away. Compulsions are more common. You could have compulsions without the obsessions. As a matter of fact, most cases of OCD, I would say, have compulsions but without obsessions. So that's obsessive compulsive disorder. PTSD, or post-traumatic stress disorder, is where a stressor, it's something that's causing some stressor. The person experienced some stressor. It's often associated with war, but it doesn't have to be war. But they saw something traumatic. And that memory of it, it's intrusive. They get flashbacks of what happened. They're remembering when they don't want to remember. They have nightmares. And it doesn't have to be one event. It could be a series of events, too. That's one common misconception about it. But it's intruding on their lives. You're trying your best not to remember it. You're trying to stay away from the scene where it happened, let's say, or something like that, or you don't want to talk about it. A person might have sadness, amnesia, guilt. There are some people who say that PTSD might have a dissociative element to it because of the amnesia, guilt, and sadness. Not surprisingly, it's sometimes diagnosed as major depressive disorder instead of PTSD, or they're diagnosed at the same time. But at the same time, they could have anxiety where they're kind of on edge, having difficulty sleeping. It's almost like generalized anxiety disorder also at the same time as well. So, but again, that kind of is simplifying, and PTSD can be a lot more complicated than that. All right, feeding and eating disorders. There's anorexia nervosa and bulimia nervosa, which are two different disorders. Some people kind of use them interchangeably, but there are some variations in common, but they are different. First, with bulimia and anorexia, there is an undue influence of body shape or weight. In other words, there's this concern about body weight or their shape when it shouldn't be there. Bulimia nervosa and binge eating disorder both involve food consumption larger than what people would eat in a similar setting. And there's a sense of lack of control. So, we all had the experience of, one eat, let's say 2 or 3 Oreos and we eat 5 Oreos. That's not what we're talking about here. This is where a person might eat the whole bag of Oreos and then move on to a loaf of bread and a box of cereal, and it can be very and they're ingesting many thousands of calories almost, and they feel like they're just like mindlessly doing it. They feel like they're not in control while they're eating. People with anorexia nervosa are typically underweight. There is a restriction of caloric intake. They're not putting calories into their body. Whereas bulimia nervosa, they are typically normal weight to overweight. And when they engage, or if they engage in those binges, the high amount of food consumption, they try to do something to undo it. Classically, they say, well, they regurgitate or throw up, but they also might, as a result, not eat. They might go for extreme amounts of exercise. I'm not talking about like, oh gosh, well, I'm going to take a walk. A person during Thanksgiving dinner might go for a walk. We're talking about they eat maybe a whole gallon of ice cream, and then they run all night with the intention of trying to undo it because they feel guilty about it. And that's, obviously something much more than just, oh gosh, maybe I should just go for a walk and burn off some calories. It's something much more than that. Okay. There can be sometimes a compensation strategy with anorexia, but not typically. Binge eating disorder, they tend to be typically normal weight to obese, and they go on these binges, they eat a lot, but they don't actually do anything to undo it. Neurodevelopmental disorders, autism spectrum disorder, once called just autism, but it's autism spectrum disorder. A person has social communication deficits. They have difficulty interaction with people to an extent, and they might go into a sort of repetitive pattern that's kind of like specific to like a specific behavior that just repeats over and over. Not always, but it can. These behavior, and it could be something in terms of behaviors, like they do something over and over, or they're so interested in something, they have such a specific interest in something that it's like just I don't want to say obsessive, but it's just so focused more than what the average person might be interested in. There used to be Asperger's disorder, and in the DSM-5 they said, okay, what we call Asperger's is actually high functioning. It's a type of high functioning autism spectrum disorder. So intellectual disability is categorized by intellectual functioning deficits, academic learning, either in academic learning or learning from experience. They have difficulty in those areas of learning. Classically, the IQ had to be below 70, but that's no longer part of it. It can be a guideline, but it's not part of the diagnostic criteria. And they have difficulty living a life, basically adaptive functioning deficits. They have difficulty living their lives with either independent living or communicating with others. So that's intellectual disability. ADHD or attention deficit hyperactivity disorder, basically 2 categories there. Inattention, difficulty focusing, difficulty concentrating on something, being very easily distracted, and lacking organization. Again, not necessarily all 4 together, but those are typical parts of the inattention. Whereas the hyperactivity, fidgety, they have difficulty standing still or sitting still. They engage in doing things without thinking about, being impulsive. They might talk a lot. Not necessarily all those things, but at least part of those things. And a person could have the hyperactivity, but not the inattention. They could have the inattention, but not the hyperactivity, or they could have both. That's ADHD. So, quick review question. See if you can do this in the chat. Difference between a positive and negative symptom of schizophrenia. I see that Jane has a question, and I will get to that at the end of this presentation here. All right, disruptive impulsive control and conduct disorder is a category that comes right from the DSM, and you don't have to memorize that category, but I had to title it with something, and so I'm using the DSM category in this unit. Every year, basically, the more I teach this, the more verbatim I take this from the DSM, because I do not want to get anything wrong in terms of what I present here or misrepresent anything. So I use a lot of their terminology. With disruptive, so basically there's two categories here: operational defiant disorder, or excuse me, oppositional defiant disorder, and conduct disorder. Both have behavioral problems that lead to issues with adults. Although both of these, well, more or less can lead into adulthood, these types of behaviors. A person with oppositional defiant disorder is vindictive. They want to get even. If they're offended, they argue with authority all the time. They get angry and irritable. And a person with conduct disorder could have those things, but the big characteristic of conduct disorder is that they have a lack of regard, empathy, remorse. They do something and they're not sorry about it. And again, this is the extreme version of this. There are, so I'm talking about the extreme manifestations here. There's that. They might harm others. They might steal. They might lie. In order to kind of get their way. Like they care about themselves and no one else. Now, again, let me say that this is the extreme. There's always a continuum of everything, but again, we're talking about the extremes here. All right, the person with oppositional defiant disorder can have remorse, can have empathy, might feel bad about what they did, but a person with conduct disorder classically might not. Somatic symptom and related disorders. Somatic symptom disorder is where a person complains about having some illness, and they think they're sick, and they just kind of they do a lot of complaining about it. Like, oh, I feel sick, and that's basically as far as it goes. With illness anxiety disorder, they might actually they feel like they're sick, and so much so they're really anxious about it, and they're, even though there's no symptoms whatsoever, they think that they might have the worst possible symptoms. The difference between this and somatic symptom disorder: the person with somatic symptom disorder might say, "Oh, this pain is too much. I'm in a lot of pain. I can't do anything," whereas a person with illness anxiety disorder might say, I must have a serious illness, and so they're often going to the doctor, getting all sorts of tests that might not be necessary. Fictitious disorder is where a person fakes a physical or psychological illness, typically to get attention. That's not to say that not to get money, not to get financial gain, usually to get sympathy or attention. There's something called malingering where they would, which is a different thing. But conversion disorder is kind of interesting because there is an actual altered motor or sensory function. They lose the vision, they lose movement in their arms or something like that. And it has no physical cause. Usually some psychological underpinning that's making that happen. It's a very interesting thing when that happens. You have that. So, all right. Gender dysphoria. Okay. Gender dysphoria is where one's current experience or expressed gender is incongruent with the gender that was assigned at birth. A person was assigned male at birth and grows up and they don't feel male. Or they may feel male and female, or they might feel fluid. It could be a variety of different things. So there's that's the typical, again, just the very basic definition of gender dysphoria there. And the thing about the incongruence, and this is very important because there are some people who say gender dysphoria does not belong in the DSM. But the reason why gender dysphoria is still in the DSM is that for some, not all, where there is that incongruence, it causes distress. And it's stressful. Now, there are some who might have that incongruence and are not particularly bothered by it. But those who might be distressed about, well, okay, and then it might seek some sort of treatment, like what can we do to like the stress or the distressing feelings less, or how to manage with it. So with sex and gender, it's the biological indicators of male or female. It's the reproductive capacity, versus gender, which is how one lives their lives, the public roles they live as a male or female. And obviously it's I'm kind of restricted to two in this presentation, but it can be it could be fluidity. There could be some say third gender, some say no gender, some say other, and there's quite a few categories. But for simplicity here, just talk about male and female. And the DSM, and I should say the AP exam sticks to two, at least in terms of this context here. Okay, so describe two episodes in the bipolar disorders. Or I should say in bipolar disorder, I should say. Okay, see if you can do that in the chat. All right, moving on here. Personality disorders, there's a lot of them. And are you expected to know them? I present them all here. First off, personality disorders are behaviors that are kind of a pattern of way that one lives their life that is just ongoing, and they don't want to change it. There's just no changing. It stays the same their entire lives. It deviates from what the culture expects them to have. You see, most of these other disorders kind of come and go in episodes, but here the entire life is lived like this. The entire life is lived in this regard, in this maladaptive pattern. And it causes functional impairment in their ability to live. Okay, cluster A, the odd or eccentric cluster. Paranoid personality disorder, persons living in constant paranoia. Schizoid personality disorder, they have no desire to talk to other people, to be with other people, no desire for relationships. Schizotypal, I mean, who ever thought to put two words together that are very similar sounding? Schizotypal is where there's odd or eccentric behaviors, like they live a very odd or eccentric life. Cluster B, antisocial personality disorder, that's where conduct disorder at the age of 18 is changed to antisocial personality disorder. It's not the only disorder that I know of, at least, where it's strictly age dependent. And at a particular age, the diagnosis changes. Lack of regard, empathy. It's basically a conduct disorder for anyone over 18. Borderline personality disorder is a strong shifts back and forth between being very emotionally close and then being very distant from someone else. They're very close and loving, and then suddenly get away from me. I don't want to talk to you. That could be someone with borderline personality disorder. Histrionic personality disorder is someone who's seeking attention all the time. They're flirtatious. They need approval and love from everyone. They kind of do things to draw attention to themselves. Narcissistic personality disorder is having an exaggerated sense of importance of oneself. It's like they have this idea that they are excessively important, and they need to have attention drawn to them. Cluster C, the anxious or fearful. Obsessive-compulsive is not the same as OCD. It's OCPD. Here, it's a person who has a rigid way of living their life. They have a very rigid way of living their life, and they don't want to deviate from that at all. They hate that kind of change. Very strict with their money, very frugal with their money, and wants to live their life in a very strict way. Avoidant personality disorders, where they don't interact with other people because they're afraid of rejection. Schizoid, they don't want to interact with anyone. Avoidant, they do, but they're afraid of rejection. And dependent personality disorders, where a person's over-relying on others all the time in order to, they're always relying on other people to do things for them, to they feel like they can't function without other people doing things for them all the time. The insanity defense is not a psychological term, it's a legal term. Insanity does not appear, as far as I recall, in the DSM. It's a legal term that refers to the defense having to prove, and sometimes referred to as the Monotone rule, that at the time a crime was committed, that a person was not aware of their actions and or was unaware of the morality, that it was right or wrong. In other words, they were unable to tell the difference between right or wrong at the time that the crime was being committed. And it's the defense who has to prove that. It's used in only 1% of the cases, and has only, in that 1% of cases, about 1 in 4 are actually ever successful. It's a very difficult defense to pull off. And even if you are successful, it's not like if you're found not guilty by reason of insanity, that you get off and live your life free and happy. There's like a forced hospitalization and then maybe some prison time following that, depending upon the crime. Okay. So that was the first part, talking about therapy here. Some challenges in therapy. So we're moving the second part here. One of the things that happens in therapy is something called transference, where a client has or a patient has certain feelings and they start directing them towards the client. So if a person has problems with their father and they constantly bicker with their father, and then over the course of numerous therapy sessions, they start bickering with their therapist, that's transference. And this is something that Freud actually talked about. And Freud gets this absolutely right, that this does happen in therapy, and therapists have to be trained to recognize transference, because then sometimes the therapist, who has their own shortcomings and their own issues and their own problems, we all do, might start taking their insecurities or feelings and start directing towards the client. So let's say that therapist has a tendency to put down his kids, let's say. And so when the therapist gets this, bickering, starts putting down the client. And that's where it can become quite maladaptive, the therapy. So that's countertransference, where the therapist starts directing his or her feelings towards the patient. Spontaneous recovery is where a person just suddenly gets better, and it's not so much a problem, but if you're trying to see whether or not a therapy works, a person suddenly gets better, and you say, well, the therapy worked. Well, did the therapy work, or did they just happen to get better? The placebo effect, it's the where you have this expectation of healing, and the idea behind the placebo effect is that it's not that. Everyone acknowledges that just about every treatment out there has a placebo effect to it, some placebo effect. The question is, how much better is the placebo effect compared, or I should say, how much is the treatment compared to placebo? Because if the line on the right represents how many people got better with the treatment, well, a certain amount of that is due to placebo, the expectation of getting better. And so how much better is the treatment compared to placebo? That's the issue there. And sometimes there are treatments that are said to work, but when you look at the data, they're only as good or slightly better than the actual placebo. So that right there would be the theoretical treatment effect. All right. Real quick review, the difference between obsession and a compulsion. The difference between obsession and compulsion. Can you remember that in the chat? See if you are able to remember that. Regression to the mean. This is something I debated putting this in the CRAM because it's a really, I don't want to say it's obscure, but it's a pretty complicated concept to talk about in a quick review. But so basically, regression to the mean, I'm going to talk about, suppose a basketball player is known to make 60% of averages, 60% of shots on average in a basketball game. Does that mean that they get 60% each time they shoot the ball, or that it's exactly 60% every game? The answer is no, because let's say this line represents 60%, okay? So let's say everything above is a game that's above 60%, and the one in red is below 60%. Well, it just so happens some days that basketball player has games above 60% and games below 60%. Well, look what happens here. You look at the days here, and you can see that, wow, he had some really good games, and wow, but then why did they go up? Like, this person was doing really badly on May, was at 10th, and then they had a strong increase, and May 28th they were not doing well, but then they got really, really good over the course of 2 weeks, and then there were times when they just tanked. Why the decrease? Were they doing something good or bad to make those increases or decreases? Well, no. It's because that sometimes when you're a 60% basketball player, you're going to have games above 60% and some games below 60%. And if you're having games above, well, guess what? There are going to be times when you're just going to go down, because that's how averages go. You eventually revert towards the mean. It also can be used in wellness here, because here's the thing. If average well-being is that line in the middle there, and a person goes to therapy who happens to have, dots below, meaning they're not doing as well. But let's say that line represents their actual average. Well, guess what? If you start off being really low in terms of your wellness, guess what? There's only one way you can go, and that's up. Okay. Actually, I'm going to skip. Basically, it's the same idea. If I gave you a quiz and I just asked you to keep guessing, well, guess what? There are going to be times when you do really well and times you don't do well. But if you're just guessing, guess what? You're going to have up and down fluctuations. Same thing too with mental health awareness, which is regression to the mean. Why are you going up or down? Well, it just means that just happens sometimes. That's regression to the mean. An eclectic approach is usually what is most commonly used today in therapy, meaning that they're not strictly behavioral, they're strictly cognitive. They use a combination of, let's say, medication. Now, only psychiatrists can give medication in most states, but in general, when it comes to therapy, it could be a combination of different types of therapies, and maybe they go to a psychiatrist for medication. Okay. Real quickly, the difference between anorexia nervosa and bulimia nervosa. Can you remember that off the top of your head as we were talking about that just earlier? All right. Some quick, brief mental health therapy history. Felipe Pinel, I think was his last name, or how you say his last name anyway, was the first one really to suggest, at least in the Western civilization, if you will, to talk about, or in modern era, I should say, to talk about treating mental illness in 1794. That maybe it's something we should possibly treat. Okay. Dorothea Dix in 1840 calls for the establishment of mental health hospitals meant to treat people, not to throw them in jail as they were doing at this time, and still doing past this time, but really saying we got to treat people. 1963, Kennedy signs the Mental Health Act that basically establishes community hospitals. David Rosenhan writes the book on being sane in insane places, which has been disputed today in terms of some of the data, but basically it suggested that that hospitals, mental health hospitals, had difficulty actually differentiating those who were well and those who were not well. The biomedical medical approaches to therapy, ECT, electrocompulsive therapy, is used in depression, in which an electric current is actually sent through the brain to a person under sedation. For some reason, it seems to work, but there's a major side effect, which is memory loss. People might lose several weeks of memory leading up to the procedure as a result. Lobotomy is where they cut the frontal lobe from the limbic system, the emotional area of the brain. In people who have high psychotic episodes. This is the treatment that's not done anymore, at least not like this, because what would happen is they would have literally no personality. They would just be sitting there with no emotion for the rest of their lives. So psychotropics are medications. For depressions, we have SSRIs such as Prozac and Zoloft, and MAOIs, which basically, SSRIs, selective serotonin reuptake inhibitors, basically what it tries to do is it tries to block reuptake of serotonin, so there's more serotonin in the synaptic cleft to bind to the receptor sites to fire off the happy neurons. MAOIs, basically, MAOs are enzymes that break down serotonin. And so what happens here is that MAOIs, the inhibitors, what they do is they come in and they stop the MAOs from doing their job. And so what happens is that the MOA inhibits the MAO, which leaves the serotonin not being destroyed and can bind to the receptor sites and fire off the happy neurons. That's the way it works in theory. For anxiety, there is benzodiazepines, big word right there. Valium and Xanax basically try to treat anxiety. Lithium is the classic drug to treat bipolar disorder. It's kind of like what aspirin is to the headache, although not many people prescribe lithium anymore. Ritalin and Adderall are often prescribed for ADHD. Schizophrenia, something called thorazine or chlorpromazine, being the generic term, is a classic drug for schizophrenia. Haldol is an example of this. Just some names you need to know for the psychotropics. Psychoanalysis, or the psychodynamic approach here, basically tries to break that barrier between the conscious and the subconscious mind. That basically all your problems, according to the psychoanalytic approach, to simplify it, is that there's some repressed ideas or memories, and we got to get that insight. There's a conflict that's causing something. And so we use free association, which a person just talks whatever's on your mind, and eventually you'll get to it will slip out. You'll suddenly realize, oh, this is the problem. It might take years for it to work, but that's essentially the way it works. And you get this insight, this realization, oh, that's what it is. It's a conflict between me and my sister or my brother or whatever. And you might use dream interpretation as well. The dreams might be able to tell you something. So again, not too often used strictly as that. Humanistic therapy is often client-centered and non-directive. It was pioneered by Carl Rogers. The goal here is growth, okay, where basically a person is talking about their issues and say, okay, you know what? We're going to use active listening. I'm really going to be in tune to your problems here and listen to you. That your mistakes, yes, you make mistakes. I'm going to use unconditional or positive regard. I'm not going to judge you for the things you've done wrong. Yes, I might say you did something wrong, but you know what? You're still a good person. And then empathy, like really feeling what you feel, and hopefully we will grow together in this humanistic process. And it's this idea of congruence, that the therapist and the client are together, working together. That's that feeling of congruence when you have all these things happening. Behavioral therapies use classical and operant conditioning. Mary Cover-Jones is associated with counter conditioning, in which a specific phobia, let's say I have a phobia for dogs, might be paired with something that normally makes me happy. Let's say it's bowling. It doesn't be bowling, it can be anything that makes me happy. And so what happens here is I'm presented with a dog, but then I'm also presented with something happy. What it does is that it's going to override that unpleasant feeling and make me feel happy. And then it's quite effective when used appropriately. Let's say I have a fear of dogs, and then flooding, what they would do is they would really expose me to the stimulus to really make that thing just go away, make that fear go away, and make it become extinguished. It doesn't actually always work that well, but it happens like that. Joseph Volpe developed something called systematic desensitization, which basically is where you try to figure out what causes you no anxiety versus what causes you a little bit of anxiety, which causes you a lot of anxiety, this anxiety hierarchy, and use relaxation techniques as you feel that anxiety so that we can learn to lessen the anxiety that you feel as you go forward here. Okay, quick review here. How do antidepressants, how are they expected to work? Both the MAOIs and the SSRIs. Do you remember that? All right, behavioral therapy, some more behavioral therapies. Overexposure. This is wwhere I have an unpleasant habit like smoking. And so what I do is I'm made to smoke a lot all of a sudden. And it'll make me have make it feel an unpleasant association with it, and I'll never want to do it again. That's the idea. Aversion therapy is where I am doing an undesirable behavior and it's paired with something noxious, something unpleasant, something not happy. So I smoke, and actually, let's say it's alcohol. They put a drug in the alcohol so that when I drink the alcohol, I get sick and I don't want to drink the alcohol ever again. So maybe in this case, smoking, they play Nickelback music. And so as a result, assuming Nickelback is noxious, I'll never want to smoke again. So another type of behavioral therapy, the token behavior is where I have a desirable behavior such as not smoking. And what happens here is that I'm given a reward, a token, it by itself not worth anything. And it has no inherent value. But for when I do the behaviors, I get those tokens or those little things that I can collect and then cash in for a prize of some kind. So for every day I don't smoke, I get a token. And when I collect 4 tokens, I can cash in for some candy, or maybe I can cash in 10 tokens for a fancy meal, or for 25 tokens, I can go on a fancy vacation. Cognitive therapy is where I try to basically reinterpret, I try to reinterpret bad thoughts. Okay, so cognitive therapy assumes that it's irrational thinking, and so let's fix the faulty thinking. Let's fix the bad thinking because that's what's causing your problems here. Let's fix the bad thinking, the faulty thinking, so you'll feel better as a result. Cognitive behavioral therapy, pioneered by Aaron Beck. Basically, the idea is that how we try to work on the interaction between behaviors, thoughts, and emotions. So basically, the idea is that all 3 of those things kind of work interchangeably, and so person feels sad, so they do a behavior in which they avoid others. And because they're not talking to other people, they feel more sad. Because they're sad, they say, gosh, I feel horrible, I'm terrible. And because they feel that way, they don't see other people, and because they're not seeing other people, there's no one there to cheer them up or to give them good positive messages or something like that. And so it's this interaction between the three, and so you have to work on all three to get improvement. Okay, and so cognitive behavioral therapy basically seeks to work on all three of those things. Albert Ellis developed something very similar called rational emotive behavior therapy, and there is some differences between the two, but they are so similar. As a matter of fact, my understanding is that Beck and Ellis one time, they're both, no, Beck is still alive, but Ellis is deceased now. They were both in a talk together, and they both admitted that they were very, very similar. And for our purposes, we can kind of assume them to be the same thing, even though there are some subtle differences between the two. For the AP exam, we kind of stick to that. So, all right. That there is the presentation for this evening. I want to address some of the questions here. So if they have a compensation, why are they overweight and bulimia nervosa? Well, because basically it's when I say it's a compensation, it's not necessarily mean they're going to, it's going to undo everything. It's they're not necessarily all the time compensating for every single binge, let's say. Again, we're talking about simplistic definitions here for something that can be very, very complicated. But if they're compensating a lot, it might be of normal weight, but sometimes though I don't want to say compensate enough because that's not, what I mean, but they're still taking more calories that would lead to weight gain. So, all right. Example of fictitious disorder would be someone faking having depression or anxiety. That could be someone who they could be faking depression. They could be faking anxiety. They could be faking schizophrenia. They could be faking a physical injury just to get sympathy. Can fictitious include someone making themselves sick? Yes. Yeah. What you're talking about here, Emma, is exactly that. They could go to great ends to get that. Now, some call it Munchausen's disorder, but in DSM, it's called fictitious disorder. So, all right. What is eclectic treatment? Eclectic is just a fancy way of saying a combination of everything. No one is strictly psychoanalytic. No one is strictly CBT. No one is strictly humanistic. That there's going to be a combination of different things. And for one client, it might be this approach. And then for the next client, the next hour, it's going to be a completely different approach. So, all right. Mark asked, do we really need to know all the little details? I would say that 95%, if not 98% of what I've said this evening is fair game on the AP exam. So the answer, I guess, is yes. We know symptoms of schizophrenia, but what really is it? Well, basically, it's a combination. It's a collection of those different types of odd irrational thinking, odd or irrational behaviors. And it could be a combination. It's not all of those at once. In the old DSM-4, and previously we would talk about different categories of schizophrenia, but not anymore. Now we kind of just talk about it as one type of schizophrenia with, that could have catatonia, that could have odd or irrational thinking, that could have delusions, that could have flat affect, or some combination thereof. So, on the AP exam, they say list every single, call or symptom. Not like that, no, but it's good to know them. So, what causes it? No, we know. Well, we know that high levels of dopamine are associated with it. We know that the enlarged ventricles are associated with it. We know that there is a genetic component to it. We know it affects 1% of the population. I know of people who have parents who have had a parent with schizophrenia, and so they every so often get what might be called reality testing, like they get tested to make sure that they're not showing signs of schizophrenia. So, but the actual exact cause in terms of a genome sequence, they might have data on that, but I'm not aware of it. So, okay. All right. And it's a big unit. It's one of the big units. Basically these are 9 units and 1 CRAM for each, and they will be touched upon again, some of the major themes as we talk about them in the. We'll get to the major CRAM and other things as well. There'll be opportunities for questions and whatnot. So, all right. Any other questions I can answer for this evening? All right. All right. Well, with that, it's 7:05 this now, and so we might have some other CRAMs to attend to, so I don't want to hold you up on that. Thank you very much for your time and attention, and I will see you next week, in which we will be doing social psychology. That'll be next week. So with that, folks, have a great night. Thank you again, and take care. Have a great weekend.